Okay, so let's turn to maybe some future directions. And one area that I know we're all concerned about are those patients with CLL that progress into Richter's transformation. Anything going on in that area?
So fortunately, there's been more attention paid to Richter's in recent times over the last few years, because we're seeing more of it in these patients treated with novel agents, because these are patients probably who would have died from their CLL. We're able to keep them alive now for a few more years, but unfortunately some of them do then go on to get Richter's, which remains very challenging. So at this ASCO meeting in the past, I've presented data on a cohort of patients on novel agents who developed Richter's. We had about 80 patients in our series, and the median survival was only about 3 months. So the prognosis is particularly poor for those patients who develop Richter's on novel agents. And fortunately, there are a number of studies underway looking at these novel approaches to therapy here. And one of them is a study that we're doing actually building on the chemoimmunotherapy experience. We're using our EPOC as our backbone, but we're actually adding venetoclax to that. And so that I think is sort of the chemosensitization approach that actually was recently published in diffuse large B-cell lymphoma in the Cavalli study and looked promising there. So we're hoping that that type of approach for Richter's patients may be beneficial. Another really exciting approach at the MD Anderson is using the PD-1 blocking antibody nivolumab with ibrutinib to try to harness the immune effects against Richter's, and Nitin Jain and colleagues have seen some really dramatic responders there. But it's still the minority of patients who are responding to either of these regimens. And unfortunately, in the few cases of CAR T cells that have gone, Richter's that have gone for CAR T cells, we haven't seen the same types of responses that we see with de novo DLBCL. So that's going to be a particularly challenging group even for CAR T.
So anything else at this year's ASCO Congress that pertains to our patients with CLL?
So we've been talking a fair bit about CAR T cell therapy, and they're going to update the data on the JCAR17 study, which is a very promising CAR T product where in the data set that they're presenting, close to half of patients are achieving complete remission, relatively small numbers of patients, but that's a bit higher than we've seen with other studies of CAR T therapy, and about 3/4 of the patients in that study are getting into a bone marrow undetectable MRD. So I think that this highlights the excitement of CAR T in CLL right now. The other study that's very promising is another combination with a newer BTK inhibitor called acalabrutinib, which is a more selective BTK inhibitor, and it's being combined now with obinutuzumab for frontline and relapsed refractory patients. And the Ohio State group is updating the 3-year data for their study. And whereas before they had seen only about 15% of patients in an early data cut achieving complete remission, now it's a little over 30%. So the responses do seem to be deepening over time, and so I think that's going to be another promising regimen, although that is one that is a continuous therapy as well. So they continue the acalabrutinib after the combination portion is complete.
Okay. Now, acalabrutinib is available for mantle cell, right?
That's right.
Are there patients with CLL that you would consider using acalabrutinib now?
So I would. I think we don't have the head-to-head data yet of acalabrutinib versus ibrutinib. This is the ELEVATE study, which we hope will read out soon. But really kind of extrapolating across the different studies, it does seem that there's a bit lower risk of cardiovascular toxicity with acalabrutinib, atrial fibrillation, also ventricular dysrhythmias, and the major bleeding risk does seem to be a bit less, at least as we compare across studies. So if I have a patient who's got significant cardiac issues, if they need to go on a BTK inhibitor, and if I have access to acalabrutinib, that's often the one that I'll choose.
And if you didn't want to use venetoclax.
Right.
Right.